Edina Kovac. I'm the Director of Chapter Development at the Benjamin Rush Institute. If you are unfamiliar with Benjamin Rush and what we do and who we are, I'll give you guys a little bit of a rundown. So we are a nonprofit rooted in the professional medical field. So my title as Director of Chapter Development, I work with medical school students, pre-med students, as well as nursing students, and just medical professionals in general to aid them in networking and spreading ideas that foster innovation in the medical field and help the doctor-patient relationship prosper. So that's kind of what we stand for, what we do. And thankfully, it gives us the opportunity to connect with wonderful people like our speaker today, Dr. Morton, to speak on various issues in the medical field and how we can just make our medical system a better one. So I want to really quickly introduce Deborah. I'm sure that a lot of you guys know Deborah. That's what I'm kind of gathering, at least. But Deborah is with HQIP, or the Healthcare Quality Improvement Platform, and they are wonderful people. The organization serves to solving common issues that result in poor patient outcomes. So they do a lot of work with patient advocacy and also helping improve the medical field in general. So Deborah, if you want to go ahead and introduce our students, feel free.
Yes, for sure. My name is Deborah, and I am the Director of Programs Outreach and Education for HQIP. And I'd like to introduce to you Komal, who is a second-year medical school student at Albany Medical College, and also Lauren Dory, who is also a second-year medical school student at Albany Medical College. They are have been with HQIP for a while, and now they are helping us to spread the word on DPCs, and we're very pleased to have them with us. So I can go ahead and introduce Dr. Morton. Dr. Morton is a physician executive with outstanding interpersonal skills and a gift for building and motivating high-performance teams. He specializes in so many different things, and one of the things that really came to mind is that he was an emergency room physician, and he's also a physician executive with CVS Minute Clinic. And his specialties are management and mentoring of medical professionals, clinical trials, retail health care operations, quality improvement in patient safety and healthcare, telemedicine, and international health and medical entrepreneurship. So we're very pleased to have Dr. Morton with us, and I'm going to let him go ahead and get started. And he's going to talk to us today about what ails healthcare.
Thank you, Deborah, and thank you, Edina, and my thanks to Albany Medical College and to the Benjamin Rush Institute for having me today and allowing me to speak to you. I have done a lot of things, and I have interest in a lot of things, but what brings me here today is that I am what I call a freedom guy. I believe in freedom, broadly speaking. I believe that freedom, we should all try to maximize freedom in our lives. That means the freedom to arrange and organize our lives the way we want to do it. And specifically, when you look at healthcare, that there are some problems there, and that's what I wanted to talk to you about. If you haven't heard this sort of thing before, listen carefully. It may give you a different way of thinking about things. So there is a slide in here about my background. If you want that, you can get a hold of this presentation. I just sent it to Deborah and to Edna both, and so they can get you a copy of this if you care to look at this. But it pretty much says what Deborah just said there. So let me start by saying, overall, it's not hard to say that healthcare is not in a good place. You listen to the media, you read, and you hear about the problems with healthcare all the time. High cost, poor quality. If you've been a patient or you know somebody who's been a patient, the chances are fairly good that they have not had a completely good experience. With my background, people come to me all the time talking about their experiences and how their experiences are in the healthcare setting. And I have a very close-up view of it. My mother went through her terminal illness early this year. My father is now in the hospital for his third hospital admission in the last 6 weeks. And so I'm getting a lot of up close look. And I think everybody would agree that there are some problems in healthcare. We have exceptionally bright people. We have a lot of technology, but the system is not really working for patients. What patients, I think, want is they want to feel like the healthcare system is their ally, but they don't feel that way right now. They feel like it's something they have to go and do battle with in order to get the health care that they deserve. And then we can turn our attention, and this will be very relevant to you, is to the high level of burnout in providers, all-time highs in burnout. And that's clearly not the sign of a healthy system when so many people who are working within it, good, smartest people in the country, are so burnt out. So I know I'm starting on a very pessimistic note, but I'm actually an optimist. I'm an optimist by nature, but I'm optimistic about what's going on in healthcare as well. And so through this talk, I'll talk to you about the fact that I think there is a solution. There is a way to turn this around, make healthcare a more fun and rewarding place to practice, and easier for patients and better for patients. And for people who are medical students right now, one thing that's pretty clear is it's not going to stay like this for your whole career. Okay, it didn't stay like any particular thing during my career, and it is certainly not stable right now. So it's not going to stay like this for your career. You're going to see a lot of change. So I'm going to talk to you today about what kind of changes I would like to see. So my fundamental premise here is that the fundamental cause, the basic cause of problems in healthcare is that healthcare is not a free market. And there are lots of reasons you can look at healthcare and see lots of things that describe a system that is not a free market. So prices are high. They're prohibitively high. Medical inflation has run twice the rate of general inflation for decades now. Interestingly, there are a couple of exceptions, such as LASIK surgery and cosmetic surgery. And those exceptions, interestingly, are in areas that are not covered by medical insurance. There's a clue there about this. So prices are high. It's heavily regulated, very heavily regulated. And as often happens when you have a highly regulated environment, some of the regulations are frankly counterproductive or even harmful to the interests of patients. I use the word cronyism there because that's what it is. It's a feature of our political system that interests, organizations and industries that have an interest will spend money to get legislation and rules shaped in their favor. And you see a lot of that in healthcare. So that's another sign that we don't have a free market. A big one, patient choice is constrained. Another piece of evidence that this is not a free market is who in the world would design employment, a health insurance system that has employment-based insurance as its basis. Okay, who would do that? If you were starting from scratch, would anybody think that's the right way to do it? You'd immediately say, well, look, how are you going to take care of people who aren't working? How are you going to take care of people when they change jobs? How much is this going to cost in some industries? Are they going to be able to pay for it? So, that's another factor that tells you this is not a free market. And then finally, and this gets to the very crux of it with respect to today's talk and to the mission of the Benjamin Rush Institute, the erosion of the provider-patient relationship. So in other words, a patient wants care, a physician wants to provide that care, But there are people in the middle. There are other forces that govern what happens there. And I'm going to just, without going into too much detail, I have the article, but there's an article about a woman named Frances who fell. She's 85. She was 85 years old. She fell and broke her shoulder, shattered it. Had, an expected period of rehab. And on day 17 of her rehab stay, her insurance company cut off payment. And she basically was, to be kicked out of the rehab, even though it was clear from the record she couldn't dress herself, she couldn't bathe herself, she couldn't even handle her toilet needs by herself because of her shattered shoulder. Why did this happen? It happened because the insurance company was using an AI algorithm to predict when a lady with these data points should be able to go home. So it's one thing, to have an algorithm that says we think this person should be able to go home after 16.6 days. I believe that was the number it came up with. But it's another thing to actually cut off funding and say, that's it, that we're going to usurp and take over the judgment of the clinical team, and dictate when this person goes home. So that's just one example. I actually have a similar example in my story. I won't burden you with that story, but I've got my mother-in-law had a similar experience where the insurance company basically set the sort of rule about when she was to go home, despite her the fact that she was dropping her blood pressure every time she stood up, and was at severe risk of falling. You see on the right side of the screen that how Americans feel, and this is not surprising me when I talk to people. They'll usually have great things to say about some aspects of it, and usually their physician is one of the bright spots, but they are feeling the system is not working for them. So to me, it seems that there is something fundamental going on here. So where do we focus? If we were to ask this group to come up with a list of what's wrong with healthcare, we could easily come up with, a dozen or a couple of dozen things that are wrong with healthcare. There's not enough price transparency, the malpractice system, poor quality. You could come up with all kinds of things. I did a Google search earlier today just to see what the latest number was, and I typed in what is wrong with healthcare, and I got more than 3.2 million hits. Okay, more than 3.2 million hits. Now, they're not all individual things. Obviously you could group them into categories, but it is instructive that there's so much written about what's wrong with healthcare. And so you've got, waste and inefficiency and, technology and price transparency and all the things that, I've mentioned, and dozens more. When you've got that many things going on, you have to look for more of a common denominator. If you try to attack all of these little things, you're playing whack-a-mole. Okay, so we need to look for a more fundamental and basic explanation. And to me, that is where market forces come in. And the fundamental issue is that we don't have enough market forces in healthcare. And by market forces, what I mean is that patients are free to choose the care that they want, and they're free to choose the insurance coverage that serves their needs. And providers, meaning physicians, advanced practice providers, hospitals, entrepreneurs, and so on, are free to meet those needs on mutually agreeable terms. So market, when you see a highly regulated environment, it means that you don't have that functioning, because in a proper functioning market, you don't need to micromanage people's behavior. I'm going to take a one slide digression here to introduce you to an idea. If you don't know this concept, I'm going to introduce this to you. It's the concept of the Overton window. And this was founded or first published by the Mackinac. I think it's Mackinac Foundation. It's a think tank, and I've Mackinac something. But there you have the link there. But the idea is this: is that with respect to public policy, the ideas that become law and actually get implemented are those that, to begin with, are politically feasible and have some traction. That is, if they are politically feasible and they have some traction, then they're said to be within the Overton window. And so that means they have a chance to become policy. If they don't, if they're not felt to be politically feasible and to already have some traction, they're not going to be implemented. Politicians are not going to suggest and push for something that doesn't have at least some traction and some credibility out there. But the window can shift over time, and it can shift in response to events and to people's efforts. And so that's what I'm doing, is I'm trying to do my little part for the effort to put free market healthcare within the Overton window. So that's my goal, because the way the Overton window works out is that eventually we will come to a crisis state in our politics, or with our healthcare system, and it will become, at some point in the near future, it will become the leading or one of a couple of leading issues in an election, and the public will simply demand that we do something about it. It's too darn expensive. And so it will be that, the politicians and policymakers will see that there is a need to make a change, and they will look around for a new idea, but they're going to pick something that's within the Overton window. Today, that solution would likely be Medicare for all. And in my view, as a freedom guy, I think that's the wrong direction. And so what I think freedom lovers should be doing is working to create options and to give the public some experience with free market healthcare. And so then to help free market healthcare become an idea that's within the Overton window, so it has a chance of being implemented. Now, there are spots of hope out there, and probably the idea that is probably this piece is probably within the Overton window, certainly getting there if it's not quite there, and it's called direct primary care. Some of you may be very familiar with this idea, but you see on the bottom left the AAFP, the American Academy of Family Physicians, definition of direct primary care, and it's a good one. Essentially, you pay a fee, and it's these. We're not talking about really high fees. We're talking about $100 a month or something like that. But you pay something, and it covers most or all of your primary care services. And these services are known right now. Direct primary care attracts physicians, primary care physicians, who are interested in the way primary care was practiced before, when the physician did not feel like they were on a treadmill. They took as much time as they needed to with their patients. They talked to them, they met their needs, and they didn't feel like they were limited to 15 minutes in the room. So there are over 1,000 of these practices in the country, which sounds great until you think about the fact that that's about 20 per state. So that's not many. That is a tiny, tiny fraction of primary care in the US. But I think this is growing rapidly. And if you have thoughts about going into primary care, I would encourage you to take a look. Get this website, take a look, because I think there is a lot about direct primary care to recommend it. One of the fundamental problems is there are too many entities between the provider and the patient. And one of those big entities that causes a lot of problems is payers, insurance companies. And so by cutting them out of the equation, the interaction is between the patient and the provider, and that's the way it needs to be. That's what makes for a healthy relationship for the doctor, and it makes for a healthy relationship for the patient. Now, there are other types of cash practices as well. For example, imaging centers, but they're less common than direct primary care practices. And I don't, I'm not saying that we've got the opportunity to make the entire healthcare system, cash practices. I get it. I get the unrealistic nature of that. There are certain things that happen that you're going to need health insurance for. I mean, but health insurance in a free market system would be for those things that you can't afford to pay for. And that doesn't mean that's not routine care. It means if you're hospitalized, if you have to have surgery, the things that are uncommon, then that's what insurance should be for. I liken it a lot of times to automobile insurance. If your automobile insurance paid for fill-ups and oil changes, then that would be equally a mess. They would tell you where you could fill your car up, where you could get your oil changes. They would say, no, you can't change your oil at 3,500 miles. We think it needs to be 5,000 miles. You'd have all of that kind of stuff going on there, but we don't do that. And consequently, you can get an oil change about anytime you want to in 20 minutes. You don't even have to get out of your car. Okay. So, anyway, I think direct primary care, this is just a pitch for that, because I think it's the best evidence or the best example today of where free market forces are coming to bear a little bit. And I will get this to, let's see. Well, all right, let's try to, I can't get my thing to advance here. Let me just see. I'm trying to do that. All right, do that. Work. Might have to, oh, my computer has frozen. I'm sorry about that. Okay, let's see. Oh, don't know why that happened. All right, I'm probably gonna have to shut the program down. And,
Dr. Morton, would it help if Edna maybe shared your slides?
yeah, and if you want to try that, that would be really good, because I'm not even able at this moment to get it um, to end the task. I can't get it to get Task Manager to work. All right. Just tell me when you've got it up.
Okay, I have the PDF version. Is that all right? Or are you able to send me
Yeah,
the slides? Okay.
yeah, that's perfectly fine. As
Yeah.
long as it'll project.
Yes. Okay.
Yeah, I got no idea what just happened to my technology. Let me see. I'm going to stop sharing. That's actually probably what I should have just done at the beginning, is stop sharing and then try sharing again. There you go. So if you go down to slide 9.
Yep. Do you see it?
All right. I think that's 10, but that's fine because that's good. I'm getting there.
This
Okay,
one?
yeah. So I was
Yeah,
just
I
going
got
to mention that there are other types of cash practices like imaging centers, but they're less common and they've got a ways to go. And I do recognize that it doesn't cover everything, but it's the best option we have to introduce some free market healthcare into the country right now. Okay, next slide, Edna. Thank you. Okay. So if you have some sympathy with the ideas that I'm putting out here, how do you go about trying to support free market healthcare? If you think that more free market in healthcare will make your career more satisfying, what do? What are the things that you can do? So let's start with general principles. And I think one of the first general principles is this is not a partisan issue. Both parties have bad ideas about healthcare. The fundamental function of politics is that politicians take money from some voters, hopefully without them noticing it, in order to use it to buy votes of other voters. And so there's always a tendency in politics to want to give things to people, for the government to give things, because that's how you get votes. So you're swimming against that stream, and both parties do it. It's not a partisan issue. You need to take personal action where you can. There are plenty of places where you can try to take personal action, and we'll talk more about that in a second. But there are also organizations that support these kind of ideas, and that you can support those organizations with your money, with your time, with your support. It is going to be necessary to organize and form alliances. That's what a lot of the organizations are. They are collections of like-minded people. Um, you We do need to trust patients. They want the same thing you do. And there are certain times when, as physicians, we still have a tendency to be paternalistic sometimes. When it comes, this comes up when we talk about deregulation. We say, well, I don't want to deregulate that because patients aren't capable of making those decisions. People make lots of decisions about very complicated things that they don't understand intimately. But what they do is they hire experts. And that's what, can be done in healthcare as well. So we have to resist the urge to be paternalistic, and we have to trust patients. It's important to focus at both the state and the federal levels. You hear mostly about this on the federal level, but most healthcare regulation is at the state level. That's where insurance is regulated. That's where medical boards and nursing boards operate. That's where healthcare, facility licensure occurs. That's where certificate of need laws get passed or repealed. So you have to pay attention at both of those. Medicare is a federal program. Medicaid is a joint federal state program, but it's implemented and administered at the state level. So again, a reason to look at the state. And then you got to play the long game, because this is a thoroughly entrenched system that is going to take a long time to change. All right, next slide, please. All right. So let's go back to the question of individual actions. If you're an individual, and this really goes for any kind of idea, any sorts of ideas. If you're an individual and you want to try to help get your ideas out there, what are ways you can do it? So one thing is write editorials or op-eds. Generally an editorial is short. The paper will tell you what it's limited to. But you can also write what's called an op-ed, and that is a longer column. And they're a lot more picky about what they write there. But you, as a medical student or as a physician, you will get a lot of deference from journalists, because you have inside knowledge, and you should not be shy about writing editorials and op-eds. I end up writing a letter to the editor of my local paper, about twice a year, about any number of things. And I have written some op-eds about healthcare. And generally they get published, because there is some deference to people that are insiders, that have that inside perspective. So don't be afraid to do that. Write to your elected representatives. Again, they will appreciate your knowledge, your education, and your perspective. So write to your elected representatives. If any of you are politically inclined, that this is an excellent way to further free market healthcare, is to get people into office who are interested in a free market platform. The next couple of things, mentoring and teaching. All of you, whether you realize it or not, will be mentors and teachers throughout your career. Okay, some of you will undoubtedly do it formally as formal teachers. Some of you will do it, on the side. You'll agree to have a medical student or a resident, in your practice for a while. But all of you, at a minimum, will do it informally. There will be other physicians, there will be students, there will be nurses, there will be all kinds of people around you in the healthcare system who will respect your viewpoint. And I'm not saying that you have to, take a soapbox to work every day. I certainly don't think that's wise. But you will have opportunities to question things that are happening and to tell people that you think there's a better way to do things. So just realize that you will be a teacher and a mentor through your entire career, and you can take advantage of that to help people realize that there are other ideas out there. And then finally, support organizations. Next slide, please, because we do get more done when we band together. And so there are many organizations that champion free market solutions, and here are just a few. The Cato Institute is my favorite think tank because I am philosophically a libertarian, and so they cover healthcare among many other things, but they look at it from the federal perspective. They're focused on Washington D.C., but most states also have a free market think tank, and they will likewise focus on a number of issues, including healthcare. So check in your state, and you'll usually find a free market think tank. The Free Market Medical Association focuses on matching employers, just like you see there, with direct primary care and cash practices. So you see their website. Benjamin Rush Institute, exposes medical students to these kinds of ideas, just like they're doing today and right now. Pick one or more of these organizations, join, donate, contribute your time and talent, and they're doing great work out there. And I honestly, until I started getting into this kind of thing about 20 years ago, really had no idea how much think tanks influence policy. When we talked about the Overton window, that's really what think tanks are focused on doing, is getting their ideas into the Overton window, if they're not, or if they are, keeping them there and getting the ear of policymakers. And people that are doing this understand that not every moment is the right moment, but they want their idea there, and they want their idea to have currency, so that when the time comes for a new idea, their idea has currency. Okay, next slide. Okay, that's the end of that about freedom. That's the end of that little piece. But I was asked also to talk a little bit about advanced degrees, particularly an MBA. And my comments are going to hold best for an MBA or perhaps an MHA, a Master's in Health Administration, and maybe not as much as an MPH, a Master's in Public Health, although to some degree maybe will apply there a little bit as well. But I have an MBA / MHA. It was a combined degree program that, I got an MBA and an MHA, and I did that well after I got out of medical school and done with residency and had practiced for about 10 years. So I do have a perspective on that, on what value it brings and whether it's necessary and desirable and that kind of thing. And the answer, is it valuable? Is it necessary? Is it desirable? It depends. Okay. It really does depend. If you are focused on getting out and practicing medicine, and you really don't want to be bothered with the business side of medicine or the policy side of medicine, or holding any position other than a purely clinical position, and believe me, that's an admirable perspective, then you probably don't need one. Okay. I would also say, is it an absolute necessity for anyone? No, it's not an absolute necessity for anyone. However, getting an advanced degree does do a couple of things. One thing it does is it teaches you the vocabulary, and that sounds like I'm trivializing it, but I'm not. Let me explain that. For everything you do, everything you study, one of the things you do is you learn the vocabulary. But the vocabulary represents the concepts that are important in that field of study. Okay, so you can learn on the business side the vocabulary of, internal rate of return, for example, in finance. Well, it's nice to understand that and understand the concept, but to understand the phrase and to be able to use it or understand it when you hear it. But it's more important to understand that that's the way business people think. Okay, that's the important thing, is they think about things. If they're going to invest money, they think about it in terms of rate of return. So it teaches you the vocabulary, and that comes in handy, but more importantly, it teaches you the concepts behind it. And business people use a different set of concepts than medical people do. So I do think it has value if you are looking at doing anything, outside of a purely clinical role. It's not necessity by any means. It is not absolutely necessary, but it does teach you the vocabulary, teaches you the concepts, and it also can serve as a little bit of a merit badge. And I don't mean that in a bad way. It goes on your signature line and it demonstrates to people that, okay, you've put in some work to understand this side of healthcare, the business side of healthcare. So it does depend. It's not necessary for everybody, but it really does have some use, particularly if your view of healthcare is sort of like mine was, where you go, I find administration interesting. I find that stuff interesting, and I sort of want to know what's behind the curtain. You know, so in those cases, it's very helpful. So how to make use of your degree, and I'm just gonna. This was my sort of brainstorm stream of consciousness about the ways that, if you're going to have an MBA, you got it for a reason. And so here are some ways that you need to think and behave that you might not have thought of before. So first of all, volunteer to take roles that nobody wants. Early in your career, these will usually be unpaid roles. Okay. But, there may be, in your practice or in your residency, even, there may be a role that requires somebody to step up and do something, and step up and do it. If it has to do with the administration of your residency, your department, something like that, step up and do it. Volunteer for a committee. When you get out and you're in practice, hospital leadership, the medical staff committees, the medical staff structure, it's a great way to volunteer. They have, committees. They have infection control committee, and they have all kinds of committees, and they need doctors to volunteer their time to do this. And it's a great place for you to demonstrate leadership and to demonstrate depth of thought and that sort of thing. So be willing to volunteer and take roles, particularly if no, well, even if other people want them, but particularly if nobody else wants them, step up. You'll learn something, you get exposure, and that kind of thing. Um, Really important. The next bullet there is know the difference between a CV and a resume. Now, you guys may not be familiar with either one right now. I'm going to talk about it like you're not. Some of you will be familiar with one or the other, but the CV, which stands for curriculum vitae, is the document that you put together to sort of lay out all of your education and your qualifications and your experience. Okay. It's that document that you give if you're applying for a job. Okay. It's like, all right, where did I go to college? What was my degree in? Where did I go to medical school? Where did I do my residency? Was I chief resident? Where did I work before, et cetera. That's a CV, and it's set up in a certain way, and it is the usual way that you will present your credentials in the purely clinical world. However, in the business world, a resume is more often used, even for physicians. So I want you to be aware of that, because if you are, looking at an administrative role, and if the person reading your information and making the hiring decision is not a clinical person, or even if they are, but they are thoroughly administrative and have been in an administrative role for a long time, I recommend you use a resume. There are lots of ways you can find out how to convert from one to the other. And honestly, I keep both. And if you're interested in this kind of thing, you should too. You should keep both. They have essentially the same information on them, but they are arranged very differently, focused very differently. And you can look up ways to convert your CV to a resume. You can hire people to write either or both. If you want to reach out to me, I'll be glad to help you. I don't claim to be an expert, but for a couple of decades, I've had both. And so I know what they're about, but do know the difference and think about when to use one and when to use the other. If it's going to be a clinical person reading it and it's for a clinical position, the CV is good. If it's an administrative role, and particularly if it's an administrative non-clinical person reading it, then yeah, you need a resume. Okay, and you can always ask the person that you're going to send it to. If they're asking you for it, you can ask them which one they would rather have. That assumes you have both, right? Which is why you should. Um, the next bullet is I'm a big believer in networking. I'm just a believer that we should all be lifelong networkers because you just never know who you're going to meet. And I could do a whole talk on networking, but let's just say I'm a believer of it in it, and I think you need to do it even when you're not looking for something. And I think you need to be bold in your networking. Okay. Truth is, most people love giving advice. And particularly as a student or as an early career physician, it's easy for you to go to someone and ask their advice and develop a relationship in that way so that you then have a relationship with them and you know them. You've had a conversation. By the end of that conversation, they should know what direction you're going in and what you're about. So be bold and be a networker. Do not shy away from networking. This same discussion goes right into the next one, mentorship. Um, Mentorship is a little different than coaching. Coaching is usually focused on a specific area and it's relatively short term. Mentorship is something that someone can be a mentor of yours for years or decades. Okay. And it is not focused on one particular issue. It is a more experienced person being available to have conversations and discussions with a less experienced person. Sometimes that results um, in advice, but often what it results in is perspective. And so I encourage you to cultivate mentorship relationships at this stage in your career and for the next 10 years. You're going to be on the receiving end, and it's going to be you cultivating mentors. And you're not limited to one. You're not limited to one at all. um, and as you move through your career, you will be on the other end of it. You will find young people reaching out to you, people that are behind you in the process reaching out. And I really believe that having somebody that you can have a conversation with anywhere from once a month to once a year, depending on your needs, and somebody that you can reach out to because you've got a big decision coming up and you just want to bounce some things off that person. It's a very valuable thing to have. Make sure you pick someone who is more experienced than you, has the kind of experience that's going to be helpful to you, and somebody that you already respect. Okay, so get a mentor. You don't have to go out and do it tomorrow, but be thinking about it. Okay. Um, Pay attention to soft skills when you are moving into the business side of healthcare, just like the business side of anything. When you get to management, or even I prefer the term leadership, because I think as a physician, you are going to be a leader if you're in the administrative and business side of things. Your medical degree is going to give you some clout that the average MBA coming out of business school is not going to have. So you're going to be a leader to start with, and when you're talking about leadership, it's all about soft skill. It's not about whether you remember the Krebs cycle, or the trying to remember brachial plexus. That's it. The brachial plexus, the anatomy of the brachial plexus. It's not about that. It's about how you handle difficult people. It's about how you manage to get things done through other people when you need their help to get things done. It's about how you support other people, how you take disparate individuals and mold them into a team. So those are soft skills, and they become increasingly important in the area of administration and management and leadership. And so for that reason, that gets us to the last bullet, which is I will recommend an organization. Now, it's not absolutely essential by any means that you join this organization, but if you have an interest in leadership and the business side of medicine and everything, this is a good organization. It's American Association of Physician Leadership. You see their website, website there. They offer several things. Number one, they offer CME for physician leaders, and the CME is based, it's largely geared towards those soft skills. It's some of it's also geared towards what's not so soft, but it's non-medical. So financial statements, how does a physician read financial statements? Which part of it is important? You're not going to try to be an accountant, but how do you read financial statements and get what you need out of them? Things like that. So some of it's semi quasi hard stuff like that, quasi solid, but a lot of it is soft skills. The things I mentioned earlier. They offer CME. They have a great job board for people that are interested in non-clinical or quasi-clinical positions, leadership positions, administrative positions. And it's a great place to network because the organization is formed by its membership is physicians who are in these roles, anywhere from very early career to very experienced, very senior people. So that's an organization you should consider taking a look at when you have an opportunity. There's my email. Also on LinkedIn. Feel free to reach out to me after the talk if you'd like.
Please consider a donation to the Benjamin Rush Institute to support student events like this one. You may donate online or by mail. And thanks for your support.